All right, great. Just want to thank you guys for inviting me, the University of Kentucky. I really do appreciate the opportunity to talk. I usually don't give a lecture in scrub cap, but today I'm gonna, just because we don't have haircuts in New York City, especially with this COVID situation. So I'm trying to save the audience from my my awful hairdo. But anyway, it's called the Corona Lecture Consortium of Residency Otolaryngologic Knowledge Attainment is what it stands for. It's out of the University of Kentucky, and I'm happy for the invite. Thanks. And I'm going to be talking today about endoscopic airway surgery. Let's see here. Next slide. All right, I have no disclosures. So we're going to talk about just the workup for any child with an airway lesion, and then we're going to kind of go over to the endoscopic management for a lot of these lesions. We're not going to go into open airway surgery. There are other talks that I think handle that very nicely. So anytime a resident's evaluating a child, you want to look at the entire SPECS-R mnemonic. So it's right over here. It's a Hollinger-created mnemonic, and you want to quantify their airway symptoms. So is it mild, moderate, severe? Is it progressing? Is it stable? Is it improving? Is there any eating difficulty? Is there any air hunger during feeds? Is there any poor weight gain or failure to thrive? Poor weight gain for me is a hallmark of what exactly is going on with this child globally. Meaning when you evaluate a child, you're seeing for maybe 15 minutes, maybe 30 minutes, but you don't know how they're doing when they're going home. And if they've got poor weight gain, and if they've got failure to thrive, and they were at the 20th percentile, and now they're sort of dropping off that weight curve, for me, in my mind, that's a big red flag. And you really got to plot that growth curve, especially in the kids under age 1. And that just gives you a global sense as to how things are going. Cyanosis or any apparent life-threatening events, that is a red flag and almost always warrants an airway endoscopy or evaluation. It's one of those things you should not take lightly if a child does have any cyanotic events. Any sleeping difficulty, just because they're doing well while they're awake and they've got laryngeal tone or airway tone doesn't mean that happens when they go to sleep. So I always ask the parents about any difficulty with sleep. And sometimes we even have them record their sleep and bring it in for review. And finally, any films done, any airway films, chest x-rays, CT scans, those are just added information. So whenever our residents evaluate a child with an airway lesion, we ask them to go through the SPECS-R mnemonic. And then even when they're transferring a patient from one resident to another resident, sign off, from like day-to-day rounds or when the services are switching, we always want them to use the SPECS-R mnemonic. It helps you sort of quantify what exactly is going on. Different parts of the airway produce different sounds. The nose, nasal pharynx produce stridor, snorting, or grunting. Oropharynx, hypopharynx produce snoring. Larynx, trachea produce stridor, and the lungs produce wheezing. So oftentimes just how the sound sounds will kind of tell you where the lesion's coming from. Today we're going to be, there are many airway regions. There's the nasal cavity, the oral cavity, the larynx, the trachea, nasopharynx, oropharynx, hypopharynx. For today's lecture, I'm just going to be focusing on the larynx and the oropharynx because they are amenable to endoscopic airway surgery. So let's start with the oropharynx. Vascular malformations. This is a video of a follicular cyst. You could have a dermoid cyst, which is sort of here on the bottom. Foregut duplication cyst, intralingual thyroglossal duct cyst, lingual thyroids. In this patient who had a dermoid cyst, sort of based in the vallecula, tiny little stalk, these are quite simple. We use a CO2 laser with a fiber optic beam. This is the Omni guide. This is before the aiming scissor, and as soon as before the aiming beam. And when you get close to the endotracheal tube, you want to use a cold steel technique so you don't cause an airway fire. When we use the laser, we usually cover the endotracheal tube with a wet pledget. And here it is coming out in block. This was nice because it just had a nice stalk. I would say the most difficult part about this case was the intubation. But interesting, this kid's missing an area epiglottic fold on that side. Moving a little lower down to intralingual thyroglossal duct cyst. This is a video we created. We actually published it as a how I do it in Laryngoscope, so you can always access the video there. But what's really important is when you're doing an airway evaluation, if the epiglottis is flipping posterior or retroflexing or going into the larynx, you want to see why that's happening. Is that happening because there's a lesion in the base of the tongue, as there is in this child's case? Or is there another reason? You can see there's a big mound sort of sitting in the base of the tongue. There it is. It's pushing the epiglottis there posteriorly. And so we'll usually insert a Lindholm laryngoscope just because we'll get a lot of exposure that way. I like to use the Hopkins rod telescope. You can also use a microscope with a micromanipulator on it. And this is what the cyst looks like. So it's located at the foramen cecum. We'll take some wet pledgets, cover the endotracheal tube. And this is the fiber optic luminous laser with an aiming beam, which is kind of nicer than the OmniGuide. And we will cauterize the entire surface. And the reason for the cauterization of the entire surface is so it doesn't bleed. And so when you grab it, you really don't get any bleed. But the other thing we do is we'll enter the cyst right at the superior aspect over here. And there you go, the cyst is entered. It's that classic mucinous material, and then we'll decompress it with a straight suction. Trying to remove these en bloc is very difficult, and you risk the lingual arteries as a result. So now here we are, we're removing about 75% of that cyst. So it's the top cap of that cyst. We try to get the lateral walls. And the goal here is to externalize this entire cyst cavity and remove as much mucosa as you can. So I'll go ahead and fast forward through some of this. You get the idea. This is the OmniGuide. Sorry, this is a luminous laser again with the aiming beam. We're also switching between that and the micromanipulator. And then we'll look for other mucosal sort of remnants. So there's a luminous laser again. So we'll kind of look for other remnants of that cyst wall and try to remove just about as much as we can. Now, you're never going to get 100% of it, but you do your best to do that. So here's grabbing just another location of that cyst wall. Kind of just trying to carve it out here, staying as close to the midline as possible. And once that is all done, then I'll put a Lindholm laryngeal spreader into the cyst wall cavity. And we'll just ablate whatever is left there, kind of cauterize the entire base, because there's going to be some microscopic epithelium there that's going to produce mucus. So we'll just go ahead and ablate the entire base there, and then we'll do a final inspection at the end. And this is what your final view looks like. Notice we stayed really close to the midline because you really don't want to ding any of those lingual arteries. 1 week post-op. Here's our view in the office. It's nice because you'll see this fibrinous exudate sort of sitting there. You can see the epiglottis is no longer flexing back, no longer retroflexing or being displaced posteriorly. And then when you look in the office, about a month out, you'll see that base of tongue area heals really nice. We've done about 8 cases like this, all endoscopically. Maybe had 1 recurrence, and that's just a little touch-up work that you do later on. But you can see the base of tongue heals really, really nicely when you do something like that. So this is our How I Do It. We just published this. It's available, I think, on electronic version. The print version will be out soon. We're going to move a little lower down to laryngeal lesions. So larynx is divided into supraglottis, glottis, and subglottis. Each one of these areas have different lesions. This is a diagram I stole from the Philippe Monnier book. I think it's a very good sort of diagram, and it's when you're thinking about laryngeal lesions and what they could possibly be. But remember, the hallmark sign here is stridor. And so if you hear stridor, you know it's coming from the larynx or the trachea. And different parts of the airway produce different sounds. So the supraglottis is going to produce inspiratory stridor. Usually that's the epiglottis and false chords. Glottis is going to produce biphasic stridor. Subglottis, also biphasic stridor. And the trachea, it's usually expiratory greater than inspiratory stridor. And when you go down into the intrathoracic trachea, it's mainly expiratory and not really too much of an inspiratory component. The cervical trachea will have an expiratory greater than inspiratory, so it can be biphasic in the cervical trachea. So we'll just start with something basic like laryngomalacia. Most common cause of stridor, as you saw in that Monnier diagram. Most common laryngeal lesion. The symptoms are inspiratory stridor, difficulty eating, reflux. Time frame usually begins in the first few weeks of life and peaks around 3 to 6 months. You know, we found at our institution that if you have stridor within the first 5 days, meaning while the child is still in the hospital, those kiddos go on to having more severe case laryngomalacia, go on to needing surgery. While if they present later, it's less likely, but still possible. This is just sort of anecdotal. We're looking at it. We're reviewing our cases right now to see how that sort of pans out, but just something to think about. And there are three types. There's type 1, which is just prolapsing of the arytenoids. You can see the AE folds are relatively lax, and that's why that epiglottis isn't curled. In type 2, the epiglottis is really, really curled, and that's because those AE folds are super tight. Those arytenoids also prolapse in. I'd say for all intents and purposes, type 1 and type 2 oftentimes will occur together, and the surgery is similar for both. Type 3 happens in less than 5%, and that's when the epiglottis actually flexes or retroflexes all the way into the larynx. And you can see, once again, we do look at the base of tongue here. There's no base of tongue lesion. This epiglottis just is prolapsing there posteriorly through the vocal cords. And that happens only about 5% of cases. And anytime you see something like this, you always want to do a neurologic workup. I've maybe found one case where there was no neurologic issue in a kid with type 3 laryngomalacia. History, inspiratory stridor increases with feeds and agitation, frequent spitting up, poor weight gain. Remember, that growth curve, super important. If they start dropping off that growth curve, meaning every calorie they're taking in, they're burning it off by breathing because they're breathing a lot faster and they're working to breathe. And you know, for little kids, that's the primary way they burn calories is by breathing. You want to look for nasal flaring, air hunger during feeds, neck and chest retractions, pectus excavatum. I always want to do a flexible scope in these kids because it may not be laryngomalacia. It could be a saccular cyst or another laryngeal lesion. I usually don't get airway films anymore, and I've moved away from proton pump inhibitors. I tend to use ranitidine if it is moderate or severe, and we'll use reflex precautions as well. So absolute indications: failure to thrive, dysphagia, aspiration, hypoxia or recurrent cyanosis, obstructive sleep apnea, pulmonary hypertension, core pulmonale or pectus. This kid's got pectus, also failure to thrive. Notice the head's very big, the rest of the body is quite cachectic, nasal flaring, rapid respiratory rate. And I'd say something about 10% of these kiddos actually need surgery. And this is how we do the surgery. It's very similar to the way Dana Thompson does it. It's cold still technique. I like to hug the epiglottis, use a curved scissor there. This is a Parsons laryngoscope. It allows easier spontaneous ventilation. Use a cup forceps to grab the cuneiforms and actually bring it posterior. So that puts a little tension on the AE folds. And usually keep dividing until you get a little bleeder, which sits right over there. I divided the other side as well. And then we'll take a curved scissor and just remove that cuneiform. So I'll actually take a piece of cartilage. I think the key here to avoid supraglottic stenosis is to really avoid that interarytenoid mucosa. As long as that interarytenoid mucosa is left intact, you can do both sides. You can cut both the AE folds. Cutting the AE folds releases the epiglottis. Dividing cuneiforms removing part of that cuneiform prevents that sort of prolapse into the airway. And this is sort of your final product. I like to use cold steel. Some people do use the laser. It's a drier surgery when you use the laser, but there is concern. Possible increased aspiration. There's some studies that show that it does, some studies show that it doesn't. And this is what they look post-op on the table. Sometimes they'll still have stridor. This is what it looks like in your office 1 week post-op. You notice now you can see the cords, epiglottis not as furled. You can see sort of scar tissue where the AE folds are, little nubbins that sort of form over where you remove the cuneiforms. And this is just 1 week out. It looks pretty good pretty soon after. So what happens if you do the supraglottoplasty and the symptoms come back again? Well, here's a kiddo where the parents stop the ranitidine afterwards, and it doesn't usually come back right away, but 2 months later, you can see here, the AE folds have sort of rescarred down. And this happens for two reasons. Number one, if the child does have reflux, it can lead to increased scarring. But number two, if this epiglottis just keeps flexing posteriorly, it can lead to those AE fold scarring again. Now, in 12 years, I've been doing supraglottoplasties, you know, over 75 cases. I've had this happen twice. In the first case, I just redivided the AE folds, and I also trimmed part of that epiglottis, and it took care of it. In the second case, I divided the AE folds, trimmed part of the epiglottis, but symptoms came back again. And that's because that epiglottis was just keep pushing back. And in that kid, I actually did an epiglottopexy, and that worked. But that actually took 3 times. The only time I've had to do a revision of a revision. So here it is, trimming the epiglottis on one side. Just use cold steel, curved scissor. Once that's done, we redivide the AE folds as well. And this is sort of what your final product looked like at the end. AE folds redivided. You can see the epiglottis is trimmed here. If this fails, then I would do an epiglottopeXy. But remember, in an infant, that's going to be difficult to do. You may be only get 1 or 2 stitches in. So here's type 3 laryngomalacia. This is an older child, Down syndrome child, type 3 laryngomalacia. Actually was doing great while awake, but when the child went to sleep, stopped breathing. And the parents described this sort of horrific pause. And this is what's happening. This epiglottis really lacks. We tend to see this in the Down syndrome kids when we do DICE. It can be associated with lingual tonsil hypertrophy. Sometimes it's not. So what we do in these cases is I like to sort of demucosalize the entire vallecula and then put a stitch from the base of tongue to the epiglottis. Nasotracheal intubation, use a Lindholm laryngoscope, operating microscope, CO2 laser in a 5-watt mode. If you're removing the lingual tonsils, I like the coblator just because it's bloodless. Use a curved alligator with a fishhook technique, 5-0 Vicryl on a taper, and a knot pusher. And so here's what we're essentially doing, demucosalizing the epiglottis, but leaving a rim surrounding leaving a rim of mucosa surrounding the epiglottis. By leaving that rim, that epiglottis still can function as that funnel. And then we tack the epiglottis up to the base of tongue. And so here's an example of doing an epiglottopeXy. Sleep endoscopy you already saw. Lindholm laryngoscope we talked about. Use a wet pledget to cover the endotracheal tube. And then this is using the OmniGuide CO2 laser to demucosalize that entire vallecular region. 5 watts, pulsed mode. Remember, you don't want to demucosalize the entire epiglottis. Once the epiglottis has been, once that area has been demucosalized, then sort of wipe it away, wipe the char away with the wet pledget, and then try placing some sutures. Now this takes some time to get good at. I like to use a taper needle, 5-0 Vicryl, make sure it's a 45 centimeter or longer suture so you can tie it. You don't want to go through the entire epiglottis. You want to just grab the perichondrium. And this, I think in this kiddo, we got in about 4 sutures. And here it is. You can see the epiglottis suspends up. This is the view prior to putting those, throwing those knots down. This is the knot pusher, and we're throwing those knots down. And this is what your post-op view looks like. You can see the epiglottis now is not even sitting on the endotracheal tube. That is a laser endotracheal tube. 1 week post-op, when you look at them in the office, you can see the epiglottis already adherent to that base of tongue there. And that's what you want. Now you got to be careful, because if these kids go on to need another surgery, and if anesthesiologist puts a Miller blade or a MAC right in that vallecula, it will disrupt your epiglottopeXy. And that epiglottis will start to retroflex again, and you'll be back to that symptoms. And that actually happened in one of the cases we did. This is in case a child has lingual tonsils, and I'll kind of fast forward through this. In office, you'll see the lingual tonsils are huge. Once again, I see this in Downs kids a lot when they fail adenotonsillectomy. Coblate the right side. Coblator. Reposition the laryngoscope to gain access to the midline. We'll coblate the midline now. I like to let the whole sort of pharynx flood up with saline. This gives you an extra airway protection. Now we'll reposition and do the left side. And let me just fast forward a little bit here, just in the interest of time. And you'll see all lingual tonsils are gone. This is what your final product looks like. And you know, if you get all the lingual tonsil, you can actually place a stitch at the base of tongue. If you leave a little lingual tonsil behind, then that stitch doesn't go through as well. It just pulls through. It's like sewing through tonsil. It's very difficult. So you saw the sutures are replaced with the epiglottopeXy. That's what it looks like. This is what it looks like after you've tied the sutures. I'd say in a 5-year-old, I can get about 3 to 5 stitches. In a 3-year-old, I get like 2 to 3 stitches. In a 1-year-old or less, I get maybe 1 stitch in. And this is what it looks like afterwards. 1 week post-op, you can see the fibrinous exudate from that lingual tonsillectomy. You can see how this epiglottis is adherent to the base of tongue. And these kids don't aspirate, because remember, you preserve the mucosa on the lingual surface of the epiglottis in a sort of in a perimeter way. So you really don't want to tie all of that epiglottis down. You still want the epiglottis to sort of act as a funnel. I'll put them in the PICU post-op with pulse ox, clinical swallow eval, soft diet for a week, discharge on post-op day 1, and we do that in-office exam 3 weeks later. We'll do a follow-up sleep study in about 3 months, and we did publish our sort of how I do it with the video in the laryngoscope as well. So let's move a little lower down to the ventricle and the false cord and the saccular cyst. It's essentially pinching off of the ventricle. Symptoms similar to laryngomalacia, treatments aspiration, marsupialization, and open excision. And we'll kind of go over aspiration and marsupialization. This video I think we published on C surgeries. Let me just fast forward through it a little bit here. So the child with a saccular cyst, you can see it's quite large, just about occupying the entire left glottis. This is the imaging study. Once again, 3 centimeters by 2 centimeters. So we'll start out by marsupila. In this case, because it was just so big, we started out with the marsupialization procedure. Let me just rewind a little bit. Put a needle in it. You'll see all this sort of pus comes out. And then what I've done after that, I've actually taken the entire roof of it off in a cold steel fashion with a curved scissor. Problem with this technique is that if that cavity is really large, there's going to be a high recurrence rate. That's pushing on externally from the neck. And you saw in that scan, I mean, this was a very large cavity. So marsupialization, could it work? Possibly. Likely. Is it going to work? Probably not. There are some people that actually go in there with silver nitrate and try to sort of denude all that mucosa, but I think in a lesion this big, that's going to be pretty challenging. But this is the sort of the extent of the lesion. You'll see we'll take a scope and we'll put it into that cavity. I mean, it is huge. So what happened in this case? 8 days post-op, in office, looks fantastic. You still see a little fullness there, but not nearly what it looked like pre-op. Problem with something like this is recurrence 7 weeks later with the next URI, because all that mucosa just kind of hung out there. So in this case, we did an extended ventriculotomy. Essentially, you're just removing the entire false cord on that side to allow for natural sort of drainage and externalization of that saccular cyst. And once again, I like to do this in cold steel. And you'll see it right here. So I'm grabbing that entire sort of medial wall of the saccular cyst, and we're cutting it out with cold steel scissors. And there it is. You're grabbing a little bit more of that wall. Get out as much as you can. Don't go crazy. Don't be super aggressive. The goal is to just create a massive defect or a massive hole there. And you know, you remove the false cord, nothing really happens. That's an afferent-soaked pledget. This is after the pledget has been removed. You can see the cords have not been harmed or touched. But you can see this cavity is quite large. And this kid actually did really good. 7 days post-op, you'll notice some fibrinous exudate in the area of that false cord where it was. Right over here, you'll see that fibrinous exudate. You see the cord still move really well. And I leave him intubated for about a day. 1 year follow-up. Kids look great. You'll still see that pretty big defect in the false cord over there, meaning or lack of a false cord on that left side there. Let's see if I can pause it on that. Yeah, it's kind of hard, but you kind of see it there. Big defect in the left cord or left false fold. Yeah. All right. So we published that paper at cssurgeries.com if you guys want to see it. So let's go on to unilateral paralysis. I'm going to breeze through this because the management is very similar to adults. Second most common laryngeal anomaly, birth trauma, cardiovascular issues are the worst. You'll hear this hoarse cry. This is what your scope will look like: hoarse brachycardia, coughing during feeds, recurrent aspiration pneumonia, hoarse cry. Usually not too much stridor. Always want to do that scope exam. If you don't have an obvious reason as to why this cord is out, you want to get an MRI from the skull base to the mediastinum. I usually don't put them on reflux meds anymore. Swallow study to see if they're penetrating or aspirating. Speech and swallow eval for thickened feeds if they are aspirating. And then we'll consider doing a vocal fold injection, but only if they're having respiratory symptoms. If they're not, then I usually like to wait till they're at least 1 year of age. And injection laryngoplasty is very similar to adults. You move the false cord over the side with the needle. kind of enter the mucosa in a stair-step-like fashion, so it kind of creates a valve for that, so it doesn't egress. You don't want to inject into the cord. And I usually do 2 spots. There you go. This is the second spot, a little more posteriorly. Remember, pushing that false cord out to the side. Really inserting that needle in a stair-step-like fashion. That's the mid-cord injection. And then this is sort of what you're left with, bulking up with the cord. So bilateral vocal fold paralysis, 30% of vocal fold paralysis is bilateral. And here, this biphasic stridor. Etiology is neurologic, idiopathic, traumatic. But look at these recovery rates, 71%, 64%, 46%. Biphasic stridor, remember that is hallmark for that. For bilateral paralysis, this is what your flexible scope exam is going to look like. Majority of these kids, I would say about half of these kids don't need an intervention, but the other half of the kids, if they just aren't doing well respiratorily or feeding wise, then in those kiddos, I do trach them and I wait, because look at these recoveries, 71%, 64%, 46%. So on average, about 50% of these bilateral vocal paralysis kids are going to recover. So if you trach and wait, oftentimes you don't have to do a procedure to the airway. But if they don't recover by 1 year of age, I'll do an endoscopic posterior cricoid split with a rib graft, where you're dividing the cricoid there posteriorly, inserting a rib graft. And the idea is to get the baseline of the cords, instead of sitting right next to each other, they sit about 2 millimeters apart, which is all these kiddos need. So we'll show you a video of endoscopic posterior cricoid split with rib graft for bilateral vocal fold paralysis. And I'll usually do this if the vocal fold function is not recovered by 1 year of age. That's the youngest I'll do an endoscopic split and with a rib graft, and I'll only do an endoscopic split with a rib graft if a child has got a trach. There are some surgeons out there that don't do it with a trach, but I do it only if they've got a trach. Or I'll put a trach prophylactically, do the split, decannulate them afterwards. So here we go. Lindholm laryngeal spreader in an inverted fashion, retracting the false vocal folds. Now I use a CO2 laser on a 5 watts pulse mode. The goal here is to divide the cricoid with minimal thermal injury. You don't want to ablate the cricoid, you want to divide the cricoid, kind of like a knife. So you want it, and you can get the small spot size with a micromanipulator. So I don't know if you noticed there, but what we're doing is I'm taking the straight suction and I push the interarytenoid muscles posterior so I can really access the cricoid. You can also push on the top of the cricoid plate, and this is what it looks like once you've divided it. Notice the posterior perichondrium is intact. You can measure the length of the cricoid division with your straight suction. But the cricoid you can see is divided through and through. Then we'll go and harvest a rib graft. Perichondrium on the luminal surface here. I use the inverted T-like fashion, not necessarily a keystone. These are our average dimensions. You can usually get a 5 millimeter distraction. Anything larger than 5 millimeters is challenging unless the child's really old. Here we go, inserting the graft in, and because we're not dividing the anterior cricoid ring, it sort of just snaps into place because there's still spring left to that cricoid. We'll reposition the graft, but it is really hard to displace. We'll cut the rescue suture. But you want to make sure those flanges are tucked in, and you also don't want to undermine the perichondrium, because if you undermine the perichondrium, the graft sits in loosely. You want to let those flanges sort of undermine the perichondrium as you're inserting the graft. And sometimes it takes 3-4 tries, but you'll get it in. And if it still doesn't go in, then you trim the graft and you try again. And this is sort of what it looks like afterwards, after the graft is in. Here we are about 1 week post-op. So that 5 millimeters of distraction that we achieved now shrinks down to about 3 millimeters because remember, that cricoid is pushing on this graft. And 1 month post-op, that 5 millimeters goes from 3 now down to like 2 millimeters. But look at the resting position of those cords, sitting about 2-3 millimeters apart. For some reason, kids with bilateral vocal fold paralysis, they can adduct, but they can't abduct. And so if you can get their resting position just a little wide open, that's all they need to get decannulated. It's a non-destructive procedure. This is an endoscopic posterior cricoid graft for posterior glottic stenosis. Here we are dividing the cricoid, perichondrium intact, a little sort of dehiscence of the perichondrium, or divided a little bit. Insertion of the graft. Day of surgery, you can see it goes from posterior glottic stenosis here to here. 1 month post-op. This is what it looked like pre-op. This is what it looked like 1 month post-op. This is what it looked like with the Lindholm false vocal retractor in 3 months. This is pre-op and this is 3 months post-op. So it's a great surgery for posterior glottic stenosis, bilateral vocal fold paralysis. We did a multi-institutional study that we published in the White Journal. It was us, Children's Memorial Hospital, where I trained, and Children's Healthcare of Atlanta in Atlanta, Georgia. I'm just going to breeze through the slides. You can pause on it and review it if you want. 29 patients. This is an updated series. I updated those numbers. 29 patients underwent endoscopic graft. Age range 1 month to 15 months. Mean follow-up was 26.7 months. 23 out of 29 had a trach present. 21 out of 23 were decannulated. Average time to decannulation was about 4 months, 4.5 months. 6 out of 29 did not have a tracheostomy. That was another institution that did that. I don't do that. All avoided a trach. All in all, 27 out of 29 either avoided a trach or decannulated. That's a 93%, which is pretty darn good. These are average graft dimensions. Some people did need additional procedures. One had a graft extrusion. I trimmed it and I reinserted it. Went well. One patient needed an epiglottoplexy. One patient's graft actually prolapsed posterior behind the cricoid. In that patient, I did a chordotomy. 2 patients had a tracheostomy placed again. One was for severe transglottic stenosis, and one was, we tried to do an endoscopic posterior cricoid split with rib graft on a failed cricotracheal resection. Lesson learned. Don't try it, because you really don't have a spring of the cricoid to really keep that graft there. Advantages: it addresses the posterior glottis. It maintains that stability of the cricoid ring. See, when you divide the cricoid anteriorly and posteriorly, you're destabilizing the cricoid. And oftentimes when you do that, you need to stent those people. When you've only divided just posteriorly, the graft just sort of snaps in, and you don't necessarily need to. Stent these people, and I don't stent them. You don't burn any bridges, meaning you could still do a chordotomy, you can still do a suture lateralization. It keeps the vocal folds abducted in the resting position, which is a lot of what all these kids need. In the posterior glottic stenosis, if you stay on top of it, that scar tissue doesn't form back again. Disadvantage, limitations. You need good endoscopic exposure. This kid, it's not going to work. Micrognathia, retrognathia won't work. Macroglossia won't work. Glossoptosis sometimes will work. Retroflexion of the epiglottis makes it difficult. It's not good for severe stenosis, transglottic stenosis, or tracheal stenosis. There is a risk of graft displacement. That's why I put a trach in. And there's need to also consent for an open procedure in case you can't get this graft in endoscopically. Postoperative care, admission to the ICU, do not remove the trach. We also put a 1 size larger trach. Humidified oxygen, swallow eval. We usually discharge them on post-op day 3. We do a follow-up DLMB post-op day 7. Tracheostomy change only in the operating room. The first trach change we'll only do in the operating room. These are the tips and pearls. I've published all that sort of in Advances Otorhinolaryngology. There's a PMID. Also published both of those videos for the posterior glottic stenosis and the bilateral vocal fold paralysis at csurgeries.com for your reference. So let's move to laryngeal clefts. It's posterior midline defect between the larynx and the esophagus associated with these 4 syndromes. Here we go, we've got type 1 through type 4B. Type 1 only intraretinoid, type 2 going into the cricoid, type 3 going through the entire cricoid, 3B into the trachea, type 4 goes into the thoracic trachea, 4B into the bronchus. So you can see how this affects swallowing. Right here, right where the swallowing occurs, it trickles right into the airway. And if it's intraretinoid, only liquids will penetrate or aspirate. So cyanosis with feeds, these kids can have apparent life-threatening events, recurrent aspiration pneumonias, they cough with feeds, the flexible scope just shows an edematous larynx. Can't really diagnose a type 1 laryngeal cleft on a flexible scope. I usually look at a video swallow study on these kids, and if it is positive for aspiration, I'll do a laryngoscopy and bronchoscopy. This is just a laryngoscopy bronchoscopy on a patient that does not have a type 1 cleft. Take that right angle probe, put it right into that intraretinoid region. You can see it's above the level of the chords there. But you also want to palpate. Make sure you feel cricoid underneath it. Speech and swallow therapy. We'll put them on some thickened feeds. This is a type 1 cleft. Goes down to the level of the chords. Super difficult to diagnose these. And some people do an injection just as a test. This is the type 2. You can see it goes past the chords into the cricoid, but doesn't go through the entire cricoid. This is a type 3. You can see it goes through the entire cricoid into the trachea. And this is that same type 3 with the laryngeal spreader intact. Esophagus back here, trachea down here. You can see not too far from the carina, only about 1.5 centimeters from the carina there. And some of these kiddos can have a high riding carina as well. So that's actually technically 3P. So traditionally, open repair. Remember, these kids need a partial laryngeal fissure. You might even be dividing the vocal cords. You're dividing the trachea in a trachea that also already has tracheomalacia. You do these opposing flaps, make sure the suture lines don't overlap. Some people put an interposition material. Very complicated when you're doing that in a 2-3-month-old. Endoscopic repair versus open. Open repair, better access, may require trach, poor voice outcomes, may exacerbate the tracheomalacia. You can have wound complication. Endoscopic repair, excellent voice outcomes, fewer wound complications, no tracheotomy. But it does require adequate access, and sometimes you can't do it in a 6-day-old. You may have to do it in a, in a 2-3-month-old, meaning put a G-tube in and wait for them to grow. So type 1 laryngeal cleft diagnostic DLB with injection has been proposed by Deepak Mehta, who wrote a bunch of papers on this. Sanjay Parikh wrote a few as well. So you just inject that interaretinoid region. I do a video swallow study about 3 to 7 days post-op, monitor for return of symptoms, anywhere from 1 to 3 months. If the symptoms don't return, well, then you're done. And the idea of the injection is just to plump that interaretinoid region, increase that barrier as if you're just kind of injecting with a little bit of a filler here, and you'll see. I just use voice gel. I don't use calcium hydroxyapatite. I want this to resorb and get replaced with scar tissue. And if the symptoms come back in, then I'll do a formal repair. But you'll see here the right angle probe will put in, and you'll see that's above the level of the cords at this point. You'll see that's above the level of the cords, and sometimes that's all these kids need. And they don't necessarily need a formal repair. And especially if you're on the fence as to whether the kid's got a type 1 or not, no downside to injecting. This is a formal repair if the symptoms come back, or if you're just convinced this kid's got a type 1 cleft. In this case, this kid was aspirating liquids, recurrent aspiration pneumonias. You can see that goes down level of cords. I insert that Lindholm vocal cord retractor in an inverted fashion. And then I take an OmniGuide CO2 laser and we're demucosalizing it in a sort of diamond-shaped area. So there you go. Take a wet pledget. And go ahead and wipe away that char. Then I like to use a 5-0 Vicryl double arm tapered needle. And the reason why you do a double arm is because it's just easy to insert. You use that fish hook technique with a curved alligator. You just insert one arm on one side, you pull it out, and then you just insert the other arm on the other side. And the nice thing about doing it this way is the knot sits posteriorly. I also like to use a dyed suture, 45 centimeters in length, because then you can see it in the office. If you're too short and you're not 45 centimeters in length, then it's going to be really difficult to tie those knots. So there you go. You go ahead and grab the suture, and you can see here the knot there is going to sit posteriorly. There's the suture kind of wrapping around. And this is just tying the sutures with the knot pusher, cutting with a curved scissor or super sharp scissors here, which you never cut on the first try or second. There you go, third try, it's charm. Release the Lindholm laryngeal spreader. You'll see that that is above the level of the cords now. And like I said, the nice thing is 1 week post-op, you can see your purple suture. In the office, you can see if it's still holding up. So if they continue to aspirate, well, you know it's not the repair, it's probably more of a neurologic situation or a coordination issue. There's 1 month post-op. You can see that now there's scar tissue there sitting in that posterior glottis. There you go. Type 2, here's a type 2 laryngeal cleft. And in these kids, I'll actually do a mucosal incision and we'll raise 2 flaps and we'll try to sew it in a 2-layer closure. Sometimes you can just do 1-layer closure. In this kiddo, I was able to get a 2-layer closure in, and that's what that looks like. You can see multiple stitches, 2-layer closure. Problem with 2-layer closure, sometimes you'll have intraluminal knots. Here's a type 3. This is a type 3 and a 3-month-old. That type 3 I showed you initially. Well, over time, we put a G-tube in that child and let him grow, but those laryngeal cleft edges started to grow into the airway and started to cause upper airway obstruction. And that's what's going to happen. So you can only wait on these type 3s so long. So you've got to trim the redundant mucosa. I'll use a cold still technique. Boucher forceps to retract the edge medially, and then we'll use a very sharp scissor. We actually have them sharpen our scissors before a case like this. Then you'll pull the other side. Remember, measure twice, cut once. So you cut the laryngeal surface of the mucosa first, then you cut the esophageal surface of the mucosa. It's very difficult to get the scissor on both edges at the same time. The key is to remove all the mucosa, especially down at the apex of that cleft. And this is what it looks like after the mucosa has been removed. The suturing is the hard part. So we'll use a bent needle and an RB1 needle, 6-0, PDS, sometimes a 7-0. So you got to bend the needle. And really getting that first suture is the hardest, and it is the key suture. If you can get the first suture and you know you're going to get the rest of the sutures in. Also, it's important to not to trap the esophagus. These are not pusher. I'll put in about 4 throws. I cut the suture, and now this is the 3rd suture being placed. You can see significantly easier. You can see that needle is bent. And you don't want to cross your sutures. You don't want to trap that esophageal mucosa. And there you go. Once again, about 3 to 4 throws. Always making sure not to sew the esophageal mucosa. And this is our 8th and last suture. So this kiddo took about 8 sutures. Remember, taper needles are important in this case. There you go, all the knots are thrown. And then at the end, to reduce the tension on your closure, we'll go ahead and divide the area epiglottic folds on both sides. There's no downside to doing this. It just decreases the tension on your posterior glottis. And this is what it looks like when you're done, in real time, not fast forwarded. And you can see there, still it's got tracheomalacia. This is why doing an anterior approach or an open approach could be challenging, because you can make that tracheomalacia worse. This is what it looks like 1 week post-op. Just checking to make sure everything's intact. And it is, but you can see there's that tracheomalacia. And then if that looks good, I'll do another DL about 3 to 4 months. And this kiddo had a G-tube, was removed at 9 months. So this is the DL at 9 months. You can see this interretinoid region still has got a little redundant tissue, but not really prolapsing into the airway. This interretinoid region is above the level of the cords. This closure goes great all the way down. And that kid actually ended up doing great. So that is now 5 years old, tolerating a full diet. One thing I did want to mention was a posterior cricoid cushion, first described by Colti. These are things you do not operate on. It is normal. It is considered physiologic. I would encourage you to read the Hoff and Colti paper. I believe it was in JAMA Head and Neck. Very good review paper, but look, you can see a dilation of vessels posteriorly, and they can be in different sizes. This is a relatively small one, but now once I showed it to you, you're going to see it every time you scope a child, an infant. And here it is. This is a bigger one. This one can appear to be a vascular malformation. It is not, especially if it decompresses when the child isn't crying or valsalvaing. Those are non-operative cases. So let's talk about laryngeal web, incomplete recanalization of the laryngeal tracheal tube, dysphonia. Some kids will have airway obstruction depending on how bad it is. The scope will show laryngeal web, management, airway film. You want to make sure that this isn't just the tip of the iceberg and doesn't extend to the subglottis. 30% of these kids will have subglottic stenosis. Always want to get a genetic eval for velocardiofacial syndrome and Georgia syndrome, which is all part of that 22q family. Type 1 is less than 35%. There's a type 1. Type 2 And oftentimes doesn't require anything. If there's dysphonia, you can divide it. A type 2, 50%. They can have they can have subglottic extensions. Some will, some won't. The goal is to get these kids to be old enough so that when you do the repair, it's going to be a definitive repair. Now, if it's a type 3 or a type 2 with subglottic extension, well, they're going to have respiratory symptoms, and they're going to need surgery. And in those kids, we divide it, and some of these kids will need an anterior graft and a keel. Some won't. It all depends on how thick it is and how far to extend subglottically. A type 4 laryngeal atresia, of course, is going to need some sort of intervention. Here's a type 3 over here. I'll touch on subglottic hemangiomas really quick, but it's no longer a surgical disease. Biphasic stridor, air hunger. You can see these things can get really large. You always want to get an MRI to see, is this the tip of the iceberg and how deep does it extend into the neck? But these are non-operative. They used to be operative. We used to do all these sorts of treatments, and then number 6 arrived around 12 years ago when I was in fellowship. And this is what it looks like before propranolol. So this is no treatment, 90% obstructive subglottic hemangioma. This is after 4 days of propranolol. And you can see it went from 90% to about 50%. This is after 3 months of propranolol. And it goes from 90% down to all the way, probably close to 10, 15%. It's just hemangioma staining at this point. You want to keep them on the propranolol for the entire duration of the proliferative phase, which is up to 1 year of age, and then you can consider tapering it off. Facey syndromes I won't talk about, but that's just diffuse hemangioma staining everywhere. Oftentimes it doesn't work. Propranolol doesn't work on those kids. Sometimes it does, but it's a very different disease than just an isolated subglottic hemangioma. But one thing you really want to pay attention to is arterial anomalies, because they can have a single carotid, and if you give them general anesthesia, they sometimes don't do so well. Moving a little lower down to subglottic cysts. These kiddos tend to be NICU babies that have had some sort of history of intubation. They will have progressive biphasic stridor, very similar to a subglottic hemangioma, progressive biphasic stridor. And this is what they can look like. And they're often multiple, not just one cyst. And these are quite simple to manage. You essentially just take either a cup forceps or a CO2 laser and just remove, uncap as much of the egg as you can. And that's what it looks like after you've sort of used the laser to it. And they can recur, so they're going to need a recurrent DLB. I usually like to do about 1 week out and then a month out. And if that month out looks good, then you usually don't have to do anything again, especially if they're asymptomatic. So next I'm going to talk about airway balloon dilation. I'm going to really go through this super quick because it is part of endoscopic airway surgery. I wrote my tryout thesis on it as well. So rigid dilation used to be the gold standard, but then there are a lot of shearing forces, collateral injuries, very imprecise. Balloon dilation really first described in '84 by the interventional radiologist. Peds surgery did some in '91. 95, they talked about using it in the subglottis. And then in 2007, that's when that paper came out from Sobel in Atlanta at the time. It really was a primary treatment for subglottic stenosis, had some good results, and then the publications just ballooned. It was easy to use, primary treatment for thin and new stenoses. It was an adjunct to open airway surgery. It was precise, low profile, less shearing forces, oblong shape, consistent size, higher stability, resistant to motion. But it was poorly studied. It got rapid FDA approval. What size you use, what pressure you use, how long do you dilate for? Short-term acute effects, nobody studied. Long-term effects or delayed effects. Are you fracturing the cricoid? If you were, was that good? Was it bad? What about the safety? Any morbidity, any mortality? The papers talked about different balloon sizes, 0 to 4 millimeters larger than the age-appropriate airway, different pressures, 2 to 16 atmosphere, different durations. Then you started having some complications. Device malfunctions. There was an eventual recall of the 18-millimeter Clarent balloon. Documented case of atelectasis, obstructive subglottic edema, where they dilated the airway and the patient had subglottic edema to a point where the airway obstructed and the child needed to be trached or emergently intubated. Reports tracheitis, bronchial and tracheal rupture, pneumomediastinum. There were even some case reports of death. So we decided to study the New Zealand white rabbit, very similar to the child larynx. So we start with a pilot study on sacrificed rabbits. The rabbits were sacrificed for knee surgery, and we harvested their airway. And we found that a 7 millimeter balloon resulted in a cricoid fracture. So that was only 1.6 millimeter larger than the measured airway. All cricoid fractures occurred at the anterior cricoid ring. So then we said, well, okay, if we know now we can fracture the cricoid, well, what happens in a live model? So when they examine the morbidity or mortality of a balloon dilation in a live model, also want to examine the histological changes produced by balloon dilation, and determine the balloon size and pressures that result in fractures of the cartilaginous framework, and then define the upper limits of size and pressure at which balloon dilation can be safely performed. Study design, we had 42 live rabbits. You can go through all this. And then we did histological analysis. We sacrificed them on day 1, day 7, and day 30. Different balloon diameters. Each rabbit was dilated with 1 balloon diameter and only 1 pressure. And this is a rabbit larynx. So spraying it with lidocaine, did a DL, and we sized the airway with an endotracheal tube. And then finally we did balloon dilation. Once the balloon dilation was done, we did it for 30 seconds. We evaluated the airway, see if there was any endoscopic evidence of any injury, which in no rabbits did we find any. So the histological evaluation, acute mucosal injury on post-op day 1, we look for ulceration edema. On post-op day 7, we look for fibroplasia, granulation tissue, long-term subglottic diameter post-op day 30. And we also look for cricoid fractures. And we sacrificed rabbits, took 3 sections of the cricoid here. So when we looked at morbidity and mortality, 4 out of 32 rabbits had perioperative death. It happened in 1 rabbit that only went a 7 millimeter dilation, which is 1.6 millimeters larger than the subglottic diameter. The rabbit became cyanotic for 10 minutes post-op, and then the remainder of the deaths occurred in 10 millimeter rabbits, 10 millimeter balloon dilation rabbits. That is 4.6 millimeters larger than the measured subglottis. Remember, the measured subglottis was 5.4 millimeters. 3 out of 6 of these rabbits just underwent cardiopulmonary arrest for no apparent reason. All we heard was a crack. We could hear the cricoid crack, and the heart just stopped, and the respirations just stopped, and the rabbit just died on the table. We looked endoscopically, no evidence of airway injury. Interestingly, 4 out of 32 rabbits had post-operative dysphagia where they stopped, where they didn't take as much PO post-op. There was no correlation with balloon size or pressure. So this is just telling you that there is some morbidity to balloon dilation, but there's also mortality to balloon dilation. And then we looked at the histopathology. This is what my tryout thesis was on. We looked at ulceration, full thickness injury, smaller balloons, not as much, moderate, in the larger balloons, a lot more ulceration, 11 out of 11 rabbits. Looked for edema on post-op day 1, really mild in smaller dilation. In larger balloon dilations, moderate to severe in about half of them. And this is just showing some edema of the subglottis. Looked at fibroplasia. Smaller balloons, very mild fibroplasia. Larger balloons, moderate to severe, 6 out of 7 rabbits. Granulation tissue. In the smaller balloons, not much granulation tissue on post-op day 7. In 8, 9, 10 millimeter balloons, 71% had granulation tissue develop on post-op day 7. Post-op day 30, all the mucosal injury that happened in the first initial post-op day 1 and 7, it all resolved. But you can develop enough subglottic edema on post-op day 1 or 7 that requires some sort of intervention. What we did find was that with an 8, 9, and 10 millimeter balloon, the subglottic diameter was larger on post-op day 30. That's because all the subglottic edema and lesions resolved, but the cricoid fracture increased the subglottic diameter. In the 6 and 7 millimeter balloons, the cricoid did not fracture, and so the subglottic diameter remained the same. So here are the fracture rates based on balloon size. 8, 9, 10 millimeters, you can see progressively more and more fractures. The inflation pressure had no correlation with cricoid fracture, meaning whether you dilated the balloon with a 5 atmosphere or a 10 atmosphere or 16 atmosphere had no correlation with the cricoid fracture in regards to balloon size. Balloon size matters more than inflation pressure. And the cricoid fractures all occurred at the anterior cricoid. The posterior cricoid, remember, is thick. So all the fractures occurred anteriorly. So here's what we found at 8 millimeter balloons. So with a 5.4 millimeter subglottis measured at the size of 8 millimeters where you start to develop mucosal injury. The problem is you also start to develop intraoperative depth, the larger the balloon. So we created a size recommendation based on age-appropriate subglottic diameter and what balloon size you should use. We attach it to the cotton system. So intraoperative mortality from cardiopulmonary arrest reaches 50% when the balloon diameter exceeds the airway diameter by 4.6 millimeters. Postoperative aphasia may occur after balloon dilation. Significant acute mucosal injury begins on balloon size 2.6 millimeters larger than the airway diameter. Balloon sizes exceeding the airway diameter by 2.6 millimeters can generate cricoid fractures. All cricoid fractures of the anterior ring. And on post-op day 30, everyone that had a post-op cricoid fracture did have a larger diameter, but the inflation pressure did not influence mucosal injury or cricoid fracture. Limitations was it was an animal model, low power, normal airway, short follow-up, only one airway size, only one duration of dilation. The Cincinnati group then published 2 papers. They first developed an animal model for subglottic stenosis, and then they saw the impact of balloon dilation on the rabbit that had subglottic stenosis. So here we go. They were able to create a reliable grade 2 subglottic stenosis in a live rabbit model. Bug-beak cautery induced 75% of subglottic injury, followed by 4 hours of intubation, gave him a grade 2 subglottic stenosis. As you can see, there's the bug-beak cautery, here's a subglottic stenosis, and here's the long-term subglottic stenosis. So they did balloon dilation. With a 6 or 7 millimeter balloon, they got a 3 millimeter ET tube in. With an 8 millimeter balloon, they got a 3.5 ET tube. 9 millimeter balloon, they got a 3.5 ET tube with 50% cricoid fracture rate. So this is the current recommendation with subglottic stenosis. If you've got acquired stenosis, you do radial incisions, airway balloon dilation. The balloon recommended diameter is 2 to 3 millimeters larger than the age-appropriate airway. If it's congenital subglottic stenosis, then you should do an endoscopic anterior cricoid split, then do an airway balloon dilation. I think the idea of fracturing the cricoid with just the balloon is where you can get these complications of mortality as well as morbidity in regards to dysphagia. So dividing it in a controlled way, then dilating with a balloon makes a lot more sense. And if you've had a previous reconstruction, you just want to do the airway balloon dilation to the reconstructed airway. You want to do larger than that because you can break up your airway reconstruction. Limitations of that study, animal model, low power. They sacrifice the rabbits immediately after doing the balloon dilation. So you don't know what happens long-term to those people that have been, those rabbits that have been dilated. Only one airway size, only one duration of dilation. Future, change duration of inflation, longer follow-up, interval balloon dilations, meaning dilated at 1 day post-op, then look 7 days post-op and dilate again. Also using adjunctive treatments. So in conclusion, recent advances in technology and surgical techniques have allowed for endoscopic management of complicated pediatric airway problems. Newer technology should be used with caution, and one should be aware of the possible complications of their application. And that's really it. Do we have any questions? Let's see here. Looks like it's just.
Thank you. That was great. Thank you for this.
Great. Did the videos come out okay? Did they were they fluid or were they choppy?
No, they came out well.
Okay, great. Yeah, that's the one thing I wasn't sure because with the Zoom, situation.
Right, it does make them. But actually, these actually were fine. So
okay,
it all looks great.
All right.
We'll have this recorded and up on our website tomorrow morning.
Okay, perfect. Great. Thanks a lot, Sarah.
Thank you.
All right, take care.